Welcome to The Explainer. Today, we're stepping straight into the high-stakes world of the clinical detective. When a patient rolls in with an unknown, highly lethal toxic ingestion, there's literally no time for guesswork. You have to recognize those hidden signals, understand the exact physiological tipping points, and most crucially, avoid the fatal execution gaps that can actually cost a life. We're going to break down the most highly tested, highly deceptive toxicology emergencies out there. Let's get right into it.
Here's our clinical roadmap, what we call the Tox Matrix. We'll be hitting the three most highly lethal ingestions: salicylates, acetaminophen, and toxic alcohols, and then capping it all off with a massive executional pearl on hemodialysis.
All right, part one, salicylates, the respiratory metabolic interlock. Let's dive right into this.
Okay, picture this classic 50-50 dilemma. The clinical lawyer takes a quick surface-level look at a patient's low bicarbonate level and instantly argues, hey, it's sepsis or it's DKA. But the strict clinical judge? Well, the judge demands a strict calculation of concurrent primary acid-base vectors. Because if you just stop at that low bicarb, you are absolutely going to miss the true killer here.
To figure this out, we have to conduct a strict signal versus noise audit. So a patient mentioning a mild baseline tinnitus, honestly, that's just noise. The true signal is sitting right there in the arterial blood gas. Check this out. A near-normal pH of 7.43, paired with a profoundly suppressed PCO2 of 22 and a low bicarbonate. When you see this exact mixed profile, boom, that is the absolute hallmark of salicylate toxicity.
Now, to understand exactly why that blood gas looks the way it does, we really need to understand the critical physiological tipping point. Salicylate poisoning creates this crazy, simultaneous coexistence of two primary acid-base disorders. First, it directly stimulates the medullary respiratory center in the brain, which drives hyperventilation and causes an early-onset primary respiratory alkalosis. But at the exact same time, it's uncoupling oxidative phosphorylation down in your cells, which ramps up anaerobic metabolism. That leads to a massive accumulation of lactic acid and ketoacids, creating a delayed primary elevated anion gap metabolic acidosis. It is literally an absolute interlock of respiratory and metabolic chaos.
And that brings us to a massive, extremely heavily tested, and potentially fatal execution gap. Do not, under any circumstances, prematurely intubate a tachypneic salicylate patient. Why? Well, mechanical ventilation simply cannot match the patient's massive spontaneous compensatory breathing. If you paralyze and intubate them, their minute ventilation drops, and their PCO2 is going to suddenly spike. That sudden spike drops the blood pH, shifting the salicylate into its ununionized, lipophilic form. And once it's in that form, it rapidly crosses the blood-brain barrier and induces fatal neurotoxicity. So what do you do instead? You need to alkalinize the urine with a sodium bicarbonate infusion to help clear the drug. Avoid intubation until absolute respiratory failure occurs. Moving on to part two, acetaminophen kinetics, the time factor.
Let's map out the diagnostic dividing line here, shifting from the initial ingestion all the way to irreversible hepatotoxicity. The thing about acetaminophen is that it's incredibly insidious, mostly because it is completely asymptomatic during the first 24 hours. The patient feels totally fine, right? But meanwhile, their hepatic glutathione stores are quietly being depleted. So, our baseline alignment here relies entirely on the Rumack-Matthew nomogram to precisely map those serum levels against time.
Depending on the severity, our actions have to shift instantly. If the patient is stable and presents less than 4 hours post-ingestion, you administer activated charcoal and just wait to check a definitive 4-hour level. But if that level crosses the treatment threshold on the nomogram, they are now emergent. You must immediately initiate intravenous N-acetylcysteine, or NAC, to replenish those crucial hepatic glutathione stores. And if they present critical, I'm talking fulminant hepatic failure, encephalopathy, a PT/INR greater than 6.5, and an arterial pH dropping below 7.3, at that point, you're looking at an emergency transfer for a liver transplantation under the King's College criteria.
But here is the ultimate trap. The big, dumb mistake that catches way too many clinicians off guard. It's drawing a serum acetaminophen level at 2 hours post-ingestion, looking at the number and clearing the patient because the value seems quote-unquote reassuring. Listen, serum distribution is completely incomplete at that stage. Any level drawn before the 4-hour mark is essentially uninterpretable. It's a massive false negative that perfectly masks true deadly toxicity. Always wait for the 4-hour mark so you can actually plot it on the nomogram.
All right, part three, toxic alcohols.
tissue targets. So, both of these volatile, absolutely terrifying toxins present initially with an elevated osmolar gap, and that's followed by a severe high anion gap metabolic acidosis. But the real core differentiators here are their end organ ischemic profiles. First up, methanol. Methanol undergoes hepatic oxidation via alcohol dehydrogenase to form formic acid. And formic acid, it's basically a sniper. It selectively attacks the optic nerve, presenting with optic disc hypemia and central blindness. On the flip side, we have ethylene glycol, the stuff you find in antifreeze. That gets metabolized into glycolic and oxalic acids. These acids precipitate as calcium oxalate crystals right in the renal tubules, leading to severe acute tubular necrosis. Oh, and on a urinalysis, those crystals look exactly like little envelopes.
Okay, so the crucial point you need to take away here is this. Absolutely do not delay treatment while waiting for the lab. The huge mistake here is holding off on the antidote, the competitive alcohol dehydrogenase inhibitor called fomipizole, just because you're sitting around waiting for formal gas chromatography results to confirm the exact alcohol. Gas chromatography is just way too slow. If toxic alcohols are clinically suspected based on an unexplained osmolar gap, you initiate fomipizole instantly. Your one and only goal is to freeze the metabolism and halt the production of those toxic, tissue-destroying metabolites immediately.
Finally, Part 4. Hemodialysis, the executional pearl. There's this really dangerous myth out there that catches a lot of clinicians totally off guard, and that's viewing dialysis solely as a rescue therapy for when the kidneys have completely shut down. We really need to destroy that idea right now. In this Tox Matrix, hemodialysis is a primary, active clearance mechanism. Its actual job is to aggressively extract parent compounds and damaging acids straight from the blood before irreversible end-organ ischemia even happens.
The protocol for this is completely definitive. If a patient presents with a severe metabolic acidosis, specifically we're talking a pH of less than 7.25, or if they're showing visual symptoms after a methanol ingestion, you must initiate emergent hemodialysis immediately. The most frequent execution gap we see on the boards, it's delaying this therapy simply because the patient is still making urine. You have to completely ignore their current urine output. You aren't dialyzing for N-urea. You are dialyzing to physically pull the poison out of their blood before it blinds them or destroys their organs. So, as we wrap up this explainer, I really want to leave you with a provocation. Think about everything we've covered. We've seen how salicylates create this deadly respiratory metabolic interlock. We've seen how acetaminophen totally hides in plain sight behind a 24-hour ticking clock. We've mapped out the tissue targets of toxic alcohols, and we just redefined dialysis as a primary weapon of extraction. The knowledge is clear, for sure, but when you are standing in that emergency room, knowledge has to become instinct. So ask yourself, are your clinical reflexes actually fast enough to beat these toxicological ticking clocks? Keep studying, keep asking the hard questions, and I'll catch you in the next explainer.